Okay, we have two presenters joining us here this morning. David Kelly is Executive Director of the Area Agency on Aging and Disabilities of Southwest Washington. He holds a master's degree in public administration from Brigham Young University and has served in various management positions within the public and private sectors. Samantha Waldbauer is Case Management Services Manager at the Area Agency on Aging and Disabilities of Southwest Washington. She holds a bachelor's degree from the University of Puget Sound, and her career spans approximately 20 years in the field of aging, working specifically with Medicare and Medicaid recipients and identifying best practices models to employ in Southwest Washington's programs. And with that, I'd like to turn the floor over here to our two presenters, David and Samantha. Welcome.
Well, thank you very much. We're happy to be here and thrilled to share our experience with our programs here in Washington State, and specifically with the Area Agency on Aging of Southwest Washington.
And I'm Samantha Waldbauer, equally excited to be here this morning and sharing information regarding Washington's health home model, home-based, person-centered approach to improving health outcomes.
So as we move through the slides, we'll just kind of chat as we go. Our first slide that we're going to start on is just a brief review of our ASWA programs. We have Title 19, which is a 30-plus year program in Washington State, helping people age in place. We have care coordination. We are a health home lead and do transitional care as well. In addition, of course, we participate in all the Older American Act and community-based programs.
So as a part of our program base, as David just mentioned, is our care coordination organization, which will be the meat of what we're talking about today. And primarily it addresses one-on-one social determinants of health that may be adversely impacting a client's health outcomes.
It's important to recognize that we're a public-private partnership. We're a public agency, and we do what we do under the auspices of 5 county commissioners, elected officials from the Southwest Washington area. We're on the slide now that talks about the tremendous success of this private-public partnership. Wherein now the agency has, the Washington State has identified in the 4th year of the operation of the health home program $167 million worth of savings to the Medicare programs, of which half of that will be reimbursed or sent to the Washington State program. So we're now on the slide that's entitled Health Home History. This health home program in Washington State initiated under the auspices of the Affordable Care Act and was working with Washington State DSHS Department of Aging and Long-Term Care Services, as well as another department called the Healthcare Authority. In this demonstration waiver program, we've established the health home work that involves us doing work directly with people primarily on Medicaid throughout the state of Washington. This program started in 2013, and it's kind of interesting. As we started the program, we started with 0 employees and are now at about 40 care coordination team members.
So as our care coordination program has grown over time, we didn't know exactly what to expect when Washington State said, here, let's go ahead and try the health home program. We didn't know if we were going to be getting 10 referrals or 500 referrals. Turns out we were on more of the line of 500 referrals. So these ended up being a boatload of eligible clients that our state's healthcare authority program had identified as eligible persons to voluntarily agree to participate or to decide whether or not they wanted to participate in this work. To date, we've done an amazing job achieving nearly a 40% client engagement rate. We have currently over 1,500 active clients engaged with care coordination, all with their own unique health action plans. And these health action plans are programs that the clients and their care coordinators work together to identify what are their personal health goals. They can be very loosely connected or very directly connected to their health care outcomes, but at the end of the day, they are goals that are person-centered that those clients feel are important to them. About 30% of our current clients are also receiving long-term services and supports. That's what LTSS is on the slide. They are receiving multiple services through our agency, and about 75% of them, oddly enough, are not oddly enough, but are Medicare also. So they're considered the dually eligible, which will be an important piece to understand as we continue to explain the tremendous amount of savings that the state of Washington has experienced as a result of these dually eligible participants. So operationally, our health homes focus, as I mentioned, on health action plans for our clients. That is kind of the bread and butter of the work that we do and how our care coordinators support our folks. The Health Home program is directed by the Healthcare Authority, so the goal was to have some consistent practices and procedures across any organization that was participating in this work. Programmatically, the goals are to reduce service duplication, provide a very seamless and positive transition of care for those exiting the hospital or nursing facilities, reducing kind of how folks are accessing care for their chronic diseases, being able to better understand and be motivated to manage their own chronic conditions, and improving and reducing preventable hospital readmissions kind of go along with that as well. So the hospitals are usually very excited when they see a care coordinator walk into the patient's room and understand that that person's going to help walk them through this process and remain engaged with their medical care. So the Healthcare Authority, along with this, to kind of understand the structural flow of this, our state program said, hey, we're going to do health homes. However, they needed an administrative lead functionality to manage the flow of payments. So they have contracted in our state with entities called health home lead entities, and those folks then contract with care coordination organizations within their network so that services are able to be obtained in all counties of the state. So we currently, again, are a care coordination organization providing that direct service to folks for this work. Additionally, I spoke a little bit earlier about eligibility. The Healthcare Authority has identified who an eligible person is. The state of Washington has created what's called the PRISM program, and that's a predictive risk management system that takes a look at the data and how clients are actually accessing their medical care. That their activity and their habits are assigned dollar amounts. It may be very real dollar amounts or how much they are predicted to use in the future. So it assigns them an actual score. So for this particular program, if it's a 1.5 score or higher, they're considered eligible for this more intensive care coordination relationship with us. The referral process initially was there was a bit to be learned. We had to outreach and engage with essentially cold calls. So the Healthcare Authority was saying, here's your batch of eligible folks, and we would like your team to reach out to these folks, explain the program, and help them understand the benefits so that they will engage in services with us. That became an interesting learning curve. A lot of our experience has been with Medicaid case management where a client is eligible, they're choosing to participate in services, and now we are continuing ongoing case management of those services. This program was a bit different. We were reaching out to folks and asking them if they were interested in working with us to improve their health outcomes. Since our beginning as a CCO, we now have had the opportunity to also become a health home lead, which is an exciting opportunity as time has gone on.
So the opportunity to participate in this activity has brought a rich opportunity to focus on our work that previously had been connected to aging in place only, but now, as of 6 years ago, our focus included health outcomes. And the most one very exciting thing for me personally, I had spent 18 years in the field of public health and had been an adjunct professor at Washington State University talking about health outcomes in that setting, for talking about the influences of social determinants of health. And when we realized that our case managers had quite a bit of training, albeit not in the areas of social determinants of health or interacting with our clients for aging in place, when we started realizing that now we were going to participate actively in health outcomes, it was an exciting proposition for us. So our slide on influencing of social determinants of health is a reminder of that. Obviously, the social determinants of health are huge factors, and we've seen all sorts of percentages of how much health outcomes are influenced by social determinants of health. But in the simple slide here, we just took some averages and saying that, of course, the impact of improving health outcomes might be somewhere in the 30% range for provider-focused impacts. DNA has 30%. For me personally, that's a bad news that starting that balding process, not much you can do about that. But the vast area of, let's say, an average amount of 40% of the health outcomes are attributed to behavioral health. So we were very excited to participate in this arena. In that excitement, we just want to pause and restate again. I mentioned earlier that the Washington State program has had huge success in the health home arena. There was a major study that was done, and it's been redone for the last 4 years and updated by a private sector actuarial firm that's footnoted on the slide that reads huge home health success. And that footnote 3 goes to the slide, the documentation of this Medicare study. We're proud to say that in the last just couple of weeks, after we've already sent in this slide to be done by the Business Institute, the 4th year of the first 4 years of savings has been studied, and now the grand total is at $167 million in savings to the duly eligible population of the Medicare population of who we serve. It's pretty interesting in our agency. As Samantha mentioned earlier, we have about 75% of our clients are in this duly eligible population arena, and 25% are in the Medicaid-only arena. So those savings are amazing and tremendous. It's interesting to note that by contract that was worked out by our great state officials for Washington State, Medicare has agreed to give a payment to Washington State, and our state will receive approximately $82.5 million from the feds. in monies directly attributed to this Help Home program savings. The next slide shows a really interesting slide that was done by David Mancuso and B. Rector of Washington State, where it talks about lessons learned from the state's Medicare/Medicaid Financial Alignment Initiative. And I wanted to point out just two quick things here. The return on investment for this program was rated at nearly 4 to 1, so that the investments in Medicaid by the state have produced these tremendously identified savings for the Medicare program. We are yet to fully identify the actual Medicaid savings, but rest assured that they're there. I really particularly like the work that was done, noted in the fourth bullet down on the right-hand page, where participants in the program were interviewed, and they found that they wanted to get more engaged in their care, and many achieved their health goals by changing their own behaviors rather than accessing additional services. And this is back to the key point that we would like to emphasize about what we've learned, is that this work with social determinants of health by highly skilled care coordinators is a significant activity. So on to the next page, slide, Samantha.
Samantha, are you there? We can't hear you.
I'm sorry. Thank you. So wanted to highlight an article that is, at the time that we submitted the presentation, was soon to be published. It actually has been published since, and we can provide that reference information after this webinar today for folks that are interested. But it really highlights the case study about how clients kind of feel after they've participated with a care coordinator in our program. Just identifying that people who enroll in the Health Home program and agree to meet with the care coordinator have a desire to make some change in their lives, even if it's only a teensy bit, a scrap of desire. We can take that and grow it and work with them over time to improve how they receive care, change their health behaviors, and improve the way they use the healthcare system. And that's something that we're very proud of with our staff, that we really like to call them social practitioners rather than social workers, because of the level of skill and expertise and professionalism that they utilize to connect with our folks and really promote the improved health outcomes.
Okay, so now we're going to kind of try to drill down and say, well, why has there been such success in the Washington State Health Home program, and how's it different than the other great programs that are operating throughout the United States in kind of having community-based organizations deal with social determinants of health? So focusing on Washington State, let's drill down to say that we believe that our success that we've achieved in our agency, as well as the other agencies within Washington State that are actively participating in this, is that, especially for the area agencies on aging that are participating, is that we have some really great shoulders to stand on. Many of you may know that Washington State was one of the first states to do the original waiver to have people age in place. The result of that has been that we have a very sound long-term care system in Washington State. So 30 years of, we call that program here Title 19 case management. So 30 years of case management expertise is critical. There was also footnoted there a highly successful Washington State chronic care management program that was used as a baseline to what was designed here in the state. So the specific expertise and methods to do this program, you'll see the 4 items there that are listed. We're going to dwell into them a little bit more and a little bit later, but sufficient to say that we feel like this program was built upon a lot of expertise that preceded us. There's another slide that we want to really emphasize, and it's entitled Difficulties in the Startup Mode. And you see graphically portrayed there just the kind of idea of what took place here. This was a startup for us. We decided to, in our agency, separate the case managers that were doing the health home work from the case managers that were doing the Title 19 work. So we still had people aging in place, case managers, social practitioners, helping people age in place, but as a separate program. We started this, and so it was from ground zero, as I said, and there's always this interplay of collecting enough resources to do the program, and then expenditures where you have to expend more dollars when you have more referrals coming to you. And as Samantha mentioned earlier, our referrals have been ratcheting up over a time period. And now in the year 6 of this program, we're kind of leveled off where we're managing our referral base equal to our base of employees, and will expand as necessary, but it's not as rapid as it was before. There were certainly difficulties in achieving that balance. We're proud to say that we're now achieving that balance of having our expenditures be met by revenues so that we're on a break-even basis. So continuing this thought about why we're so successful, we were very lucky to have a group of people in the medical field. I believe there were 3 doctors and 3 others as students with the OHSU right across the river in Portland, Oregon. OHSU's MBA program is an excellent program. And 2 professors study for 1 year our program, and they produced a report that is also footnoted for you if you wish to look at that. But the bottom line of that report was there was a series of best practices that we identified. Those best practices are listed in the page ADSWA Best Practices for Care Coordination. And these were the 11 best practices that this study of 6 MBA students and their professors identified that were significant. Samantha and I will just talk about a few of those specific best practices now.
So as you might be able to imagine, face-to-face contact really is the driving force of this success. Our care coordinator's goal is to meet with clients in the setting of their choice, face-to-face. It really supports the relationship and the trust that they're building with the individuals that we work with. It also provides a certain amount of accountability for that client who has agreed to work with us and truly looking to change behaviors to improve their health. So that face-to-face contact can and does occur in the home, but it also occurs at doctor's appointments. It occurs in community settings where they might feel more comfortable meeting until that trust has been established. I also wanted to point out item number 5, continuous refinement of practices. I feel like as we started this program, you go at the work thinking, oh, this is going to be the best way to be able to meet all these standards and get this work done, only to find out that, okay, yeah, it worked up until this point, and then things took a different turn or an unexpected turn. requiring us to go back to the drawing board in some of our processes and procedures in order to effectively meet the requirements of our contracts to do this work, to be able to manage and retain our staff, and being able to look at how we are, how the business is being formed. And because, as Dave mentioned, we treat our care coordination organization as a completely separate entity and a separate program within our agency in order to ensure that we're managing to those needs. Staff retention is the last one I'd like to highlight. It is what we've learned when we first started this, and it's one of those things that staff retention is important. It becomes painfully clear how important it is in this work when it happens. One of the things that was very clear at the beginning is that training for this work was mandated by the state. So there was very specific training requirements that had to be met prior to a care coordinator being able to begin working with clients. That was a 2-day off-site process that only occurred certain times during the year. That's the way it still stands. And so as we hired staff, got them trained, they started the work and decided it wasn't for them, it became very challenging to be able to manage the client retention as well because clients began creating those relationships with the staff and seeing the benefits of the work that we were doing with them. So over time, I'm very proud to say that our staff retention is within normal ranges now. It's not, we've been able to really identify reasonable caseloads and expectations that folks are able to manage and really do enjoy the work that they do, and say that this is the type of case management and social work that they always wished they could do.
The couple of, on this page, a couple of ones that I wanted to highlight are number 6, the statement made by OHSU that there was a separation of financial interest. This is a rather nuanced point that I want to kind of highlight here as quickly as I can. This process established by Washington State allowed for the managed care organizations that were our tremendous partners with us to also participate and receive referrals and or be a health home lead. But as we operated this program, it became abundantly clear to us that an advantage of working not only as a subcontractor from time to time with a managed care organization in this arena, but also as a separate entity receiving our payments on a fee-for-service basis, not as a subset or a contractor to managed care. It provided us an opportunity to work shoulder to shoulder with managed care in this program, but not as a subset of a PMPM per member per month payment that we might operate on in a separate setting. So that ability to have us have a separation of financial interest, and again, dwelling a little bit deeper on that nuanced point, is that when our social practitioners work the program, they don't have to stop and think, are they influencing the financial interest of a particular company, it could be a managed care organization, or benefit them, or combat the issues that are at a clinic that maybe our care coordinators, social practitioners work with their clients. The second point that I wanted to emphasize on the best practices was to point 11 there, where we talked about the OHSU study talked about the willingness to risk fund balance, and that again is a nuanced point because we were not paid to go out and find these, secure these clients. That was an unpaid event. So we had to go to our county, my bosses, our county commissioners, and ask them, we're pretty sure we're going to lose money on this program to start until we get to a sufficient volume of clients that we would be working hard to get clients that would be reimbursed for us. So as Samantha mentioned, we were only reimbursed when we got an actual health action plan created by the clients and approved for payment. So that process, those best practices are critical, and you can read further about them in the footnoted full report by this capstone study. There's been further evidence of health home success that are in place. There was a wonderful study done by the state that showed that there was actually a 33% since the health home program was produced, there was a 33% reduction in care-sensitive hospital admissions for the health home clients. Again, you can read about that study in the footnoted area. The next slide, Samantha will take.
So the real success is in the lives impacted. That can't be a more true statement, I would say. You know, the reason why our staff stays now, and because they see the success and the goals being met by our clients. That makes them very proud. It makes them feel like they've made a difference. Very frequently we hear from our clients, you know, we hear stories from our care coordinators as we share with our state the continued successes as time goes on. Things such as homelessness and now being able to trust a doctor and actually getting the care that they're needing. Skilled nursing facility residents now able to communicate with their family better. One thing I guess I may not have mentioned is the very cool thing about this work is our care coordinators follow clients. Not only do they see clients in the settings of their choice, but they follow them regardless of their setting. So they could be aging in place at home. They could be aging in an adult family home or assisted living. They could even be in a skilled nursing facility. If they're eligible and they would like to receive care coordination services, our care coordinators are able to follow them kind of throughout the span of kind of their care and the settings that they're choosing to live in. You know, the vulnerable and exploited folks in our community are being able to have increased confidence in making better decisions for themselves, for their own personal safety, which then in turn, you know, improves their ability and willingness to connect with their medical community.
Staying on this slide here, something that I wanted to mention and clearly point out. The final statement on that slide, our interactions with ADSWA care coordinators and their feedback and input. As Samantha mentioned earlier, we struggled at the beginning, to be candid. We struggled at the beginning with staff retention in this program. It is now quite high and actually exceeds the normal staff turnover points. And I have thought about this. First of all, Samantha and our HR department here identified who would come into the program and be successful. Not only is it somebody with a degree in social work that was there, but we were looking also for people who were willing to understand that there were goals to be achieved, and that, as we interviewed and processed and told potential employees about this concept, we found later that people loved this overall ability to be held somewhat accountable for some numbers that they maybe previously had not been held accountable to. And while we were worried about that, it had to be for the success of the program. And there has been many occasions when I can say to you, as a leader, a manager of people, sometimes you get that knock on your door. People say, "Have you got a minute?" And usually they're going to come in and tell you that they're not happy with you as their supervisor or their supervisor's supervisor. But I can't tell you how many social practitioners I've had knock on my door and say to me, "Dave, I just want to quickly share with you that I love this work. It's the reason I went into social work." And I'm thinking of one person who said to me, "I've been in social work for 20 years before this job. I've now been doing this job for 2.5 years, and it's revitalized me to understand why I got into this field to begin with. I'm impacting lives in a significant way, and it's made a difference for me." So not only has this program affected the lives of the people we call our clients, but it's also affected the lives of our people that we have the honor of working with and our social practitioners. So the next slide kind of starts us talking about the fact that there have been other programs that we've utilized and implemented here and have been affected by our learning curve connected to the wonderful Washington State Health Home Program. And I'll mention these briefly, and then we'll conclude with plenty of time, we hope, if there are questions to respond to. But the first program that we would highlight here is the fact that we're doing some really solid work with transitional care services with the two major hospitals in our community here in Clark County. Clark County, just to let people know, is a population of about 600,000. It's the largest bedroom community to Portland, Oregon, and the home of two large hospital systems. Both those hospital systems have been working with us on care transitions of very difficult clients who are hard to place back into the community. We're very proud of our work in the care transitions world. We've also been honored to work with the University of Washington and be one of the sites for the Geriatric Workforce Enhancement Center. And that work has been a very good success for us, and we've been utilizing our knowledge base of working with people on social determinants of health that has really been very, very fulfilling. Just back on the care transitions, our next slide that's entitled Qualis Study on ADSWA's Care Programs is also footnoted. You could read about it more deeply, but another evidence-based thought is that there's been this study that was done by a group, analytic group called Qualis here in Washington State. They're now been renamed CoMagine, but Qualis study at the time identified a 5-month savings of $274,000 based on our care transitions at the Legacy Salmon Creek Hospital Systems, which was quite thrilling for us to acknowledge. Back on the Geriatric Workforce Enhancement Center, we have noticed that as we partnered with the University of Washington to train, help them understand their residents that were in the Southwest Washington area, understand from their medical school, understanding how to bridge the gap between clinical and communities. We're quite thrilled with that work. It's been very exciting. The GWEC program allows the resident doctors to accompany case managers on home visits, shadow family caregiving specialists, work alongside our care coordinators as noted. The GWEC experience slide indicates how many people have been very, very pleased. The residents have been very pleased with their getting to know more about community services. as a matter of fact, as a direct result of our relationship with the GWEC program, one of the GWEC leaders at University of Washington, Dr. Catherine Bennett, was given the opportunity to testify before the United States Senate Health Committee. That committee, she was very proud to highlight the work that we've done with primary care physicians and having them learn how community resources can take place. One of those stories that was told by Catherine Bennett talked about a resident, a medical residency member who saw a client that they had actually seen in their clinic that they'd actually known was working with our Health Home program, and noted in his summary of that visit to us that it was very exciting to see how beneficial the community resources were to his client. The testimony of Dr. Bennett is highlighted there with some really, in the next few slides, and it's really quite exciting. So to finish up in this slide, I will just do one quote from Dr. Bennett that they felt like the reauthorization of the GWEC program and the Older Americans Act. A quote that she attributed at her testimony is that she believed this collaboration is critical to improving the health and well-being of older citizens and reducing health care costs. So our final slide that we'll highlight is just our future hopes for the community-based organizations. We're calling, lots of times they call these CBOs. We're choosing to try to say, really, they're CBHOs, community-based health organizations. And we hope that our work here in Washington State is part and parcel and a part of the instituting of working with social determinants of health in other programs throughout the nation. And we really hope that these programs in Washington State can contribute to the national models that will be addressing the social determinants of health in a real way, in a person-to-person way that is involving the community organizations that are so talented and so valued in our nation, and specifically in Southwest Washington. We partner with many organizations that help us with this work effort. We think there's a huge challenge to add dollars to the basic rate to enable other agencies to fully participate in this program. By virtue of our volume, we've been able to get it to work for us and not go into debt as we did the program. But we hope that there will be additional dollars added to this. We hope eventually also that CMS will allow CBHOs to bill directly for community-based case management services. That's a wish upon a wish. But with that, we'll close and say that we're very pleased, Samantha and I are very pleased to have participated in this. We tried to footnote for you in the slides if you wish to dwell deeper into the items that we sought for documentation. We'd be happy to now to respond to any questions anyone might have.
Okay, great. Thank you very much, David and Samantha, for your presentation here this morning. And as we mentioned, everyone, it is time for the Q&A portion of today's webinar. So send in those questions right now for David and Samantha, and we will get to them post-haste. Just type them in using the questions box right there that you see on your screen. And presenters, let's get to it. The first question here for you, the first question is as follows. What is the #1 factor of your successful 40% engagement level going from a cold call to enrollment?
Sure, that's a great question. I would say the #1 factor that we have found, and it really has been a bit of a trial and error here, is being able to be simple and as succinct as possible as we're contacting folks on the phone in an effort to get in front of them face-to-face. Once we're able to have the face-to-face interaction is really where we're able to identify a connection, explain kind of how we would be able to support them. I think that trying to do this over the phone completely, it was very difficult and very challenging and not very successful. So once we moved from identifying actually staff who had the skill set to be able to, I guess I don't have a better word other than to say to kind of hook them on the phone with the program, being able to really get at the highlights and how this person may be able to be positively impacted by our work, and then actually being able to schedule that face-to-face to go into more detail.
And then in addition to that, I would like to emphasize the fact that we have highly skilled social people with a social work degree that or equivalent that is working this program. They have the skills for didactic dialoguing, interviewing with outcomes skill set that is really important to this work.
All right, thank you very much. Next question for you presenters. The clients that I work with are confused. What can we do to give more clarity?
Well, I guess it would depend on what is the level of confusion. Is it a matter of understanding the programs and services, or is this truly an eligible a participant who's going to be able to benefit from the services that we're providing? I guess I'll answer this with on both veins best I can. In terms of explaining the program, that's why we want to get in front of them to be able to explain more clearly what it is that we can offer them in terms of how we would work with them. It's a little bit different in care coordination in this work because they don't have a tangible thing that they get as a result of participating in this. It's very much motivational, how activated are they, how to improve their health outcomes, sort of where are they themselves in order to really benefit from the work that's happening with us to be able to kind of make some changes in behavior. If you were to look at it, is this person confused because they maybe have some cognitive impairments going on? And if that was the case, we would look at this more, is this an appropriate program for them to participate in? Because clients do need to be able to be an active participant. They have to understand what it is they're wanting to change, and as we work with them to step through that.
And I'll say, just from my perspective of learning a little bit about what on a daily basis our social practitioners go through, they tell me that when they connect to the client-directed health action plan, a lot of times the goals that people set are just profound. One of the most profound ones for me was to hear that a woman that had not been ambulatory very much, in other words, very, very rarely out of her home, when she first started working with our care coordinator, her goal was to attend her granddaughter's graduation in Greeley, Colorado. The social practitioner who was working with that person, care coordinator, was proud to say that was a really high-level goal, but she was able to get that, and that person a year later, without the care coordinator, may not have done this, but with the care coordinator, working with her, she achieved that goal of being at her granddaughter's graduation in Greeley, Colorado. So that was a pretty cool goal that I think is connected.
All right, thank you.
Go ahead.
Great. Okay, next question, presenters. What is the caseload of each staff, and what do you identify as realistic?
So we struggled with this Since the inception of this program, because you're balancing what staff can actually manage versus what is our reimbursement for the kind of the workaday work, we've landed now very successfully in the last probably year that 50 clients. So our visits, and so I guess to clarify that, that's 50 clients that are seen face-to-face every month, and visits are approximately a half an hour. So that is an average amount of time that staff are spending. So by the time they incorporate any travel time, it's give or take around an hour. So to be able to perform 50 visits in the community has been successful. Staff have been able to take vacations, have days off, and still be able to meet those expectations.
Next question.
Yes. Okay. Next question. Have you utilized community health workers in your program? And if not, how do you think it would work using CHWs?
That is a great question. We're partnering with another organization that's a part of our Southwest Washington region called the Accountable Communities of Health in this community. And they are piloting some really successful work with community health workers. As Samantha mentioned, our clients have a high rate based on the acuity rate of the PRISM score. And so we have not yet incorporated community health, the concept of a community health worker who may not have quite the same degreed approach. We're also familiar with some great programs throughout the nation that are trying to use community health workers for lesser interactive dialoguing that goes on, where we feel it's really important that that we have our level of care coordinators. But we see a great possibility of in the future working with community health workers in tandem with this program. However, because of the high acuity rate, we think we're very successful, and it's proved to be very successful using the staff that we have. I hope that answers the question.
Okay, thank you. Next question, presenters. A big issue that often challenges social programs, staff retention, is burnout and/or stress. Could you touch on any particular aspects of this program that specifically address that issue?
Yes, that absolutely is extremely important to recognize. We have a supervisor to staff ratio of, right now it's between 8 and 10 to 1. So we have care coordinator teams that have strong supervisory support to be able to kind of maintain a sense of where people's stresses are. And I know that may sound very vague, but as we listen to our staff, our care coordinators, and as we identify what things can we do in our capacity to support their work and to support their ability to maintain this in a way, as I mentioned before, we identified that 50 cases was a reasonable caseload, in addition to those months where they're able to take a week off, when they're able to have it, if they need to take a sick day or two, they're still going to be successful meeting their goals for that month. Our supervisors are extremely supportive. We do our best to make team meetings fun. We don't overly meet. So peers, as you know, support each other very, very much. It's social workers oftentimes have a special affinity to be able to really read each other and support each other in that manner. And it's kind of an ongoing, every day, every month task. It kind of never goes away. You're wanting to ensure that staff are not overly stressed because retention is so important.
Maybe we have time for a couple more questions. Mm-hmm.
Yes, indeed. Next question here for you. Are the program's implementation of the 11 best practices documented in a way that they can be implemented by other agencies who may be looking to improve their results or maybe just getting started?
Well, that's our hope, and it was the hope of the capstone study. One of the professors at OHSU pulled me aside and he said, you know, you're starting this in a really interesting time frame. This is highly needed, and the writing of their study was designed to make it applicable elsewhere. However, we recognize that Washington State has its own particular nuanced referral processes and those types of things that might make it not completely applicable. But we think the best practices, or at least speaking on behalf of the authors of the study, writing it expressly to have it be more applicable across the board.
All right, thank you.
You bet.
Okay, next question here. What relationships, if any, do you have with the accountable communities of health or other agencies, and have you found issues around duplication of services?
Well, I kind of mentioned that. It's funny, in our region here, I'm honored to be on the steering committee for the Accountable Communities of Health for 3 of our 5 counties in Southwest Washington. And then we have an association in Washington State with another Accountable Community of Health regional group. So we're excited to work side by side. In Cowlitz County, for example, we're having our care coordinators working with a really wonderful program about falls prevention with the fire districts in Cowlitz County, which is one of our 5-county regions. We're also very excited to work with the Accountable Communities of Health that are for Clark, Skamanic, Clickstack counties, three counties in our area, where we're collaborating and working and trying to understand how we can collaborate together. We're looking to be very, very effective partners as we start these efforts up, but we're excited to continue to work those partnerships out.
And a lot of that effectiveness as we're having dialogue with our Accountable Community of Health is to have these discussions about not stepping over each other and not duplicating services, and who are we targeting, and identifying those populations and trying to match those populations with the most appropriate programs.
Okay. Well, David and Samantha, unfortunately, we are out of time. We've reached the end of our hour, but I want to thank you for joining us for today's presentation and being here. Thank you so much.
Have a great day, everyone.
Thank you.